have a seat in the chair. So you are now my MS patient or stroke or whatever you have. So if I'm going through and I'm muscle testing and I'm like, okay, let's pick this knee up nice and high in the air, and you pick it up, and this side's great, and I can give you pretty good strength and everything's good over here. And then on this side I say, okay, pull it up, pull it up, pull it up, and she's really struggling. It's a 1, it's a 2. I really don't like putting this on people who are really more than a 3 plus. I'd much rather focus on strengthening, so I try and avoid using it on people like that. I want to get them stronger, not compensate. But if they're 2s, 1s, then I want to use something to try and compensate for that loss. So in her case, we're going to do that. If she has a foot drop, you know, we're going to muscle test, and she has the same strength level down there, perhaps. Then we can consider using it. But her gait is going to kind of have, you know, it's going to be that walk. Maybe a little bit better clearance. But part of the reason why this came about was I had this guy, Bob, who was an MS patient, and he came in and he's walking like this, right? So way back in the day, I put a gait belt around him and then put TheraBand around his foot, and we did gait training that way, and he's like, this is great, I love this, I can walk really well with this. And he said, I wish I had something I could wear all the time. And so it was kind of that eureka moment where you say, oh, well, maybe we need to make something that you can actually wear all the time. So this one is set up for the left side. Okay, so really all it has, so there's a few different holes up here, and you can move this. This one here, you're always going to leave in this spot. Okay, so the medial band here is always going to stay in this hole. The lateral band, you're going to adjust, okay? Because like my hips are a lot wider than her hips, so if I'm going to put it on, I might maybe slide it out 1 notch, and you have extra holes that are in there. But ideally, you want to have that aligned so it's going to come right up the medial and lateral sides of her leg when you set it, when you get it on. So when you try it, you're going to put this on, and there's really 4 steps to putting on a hip flexion assist device. So, and also just so you know, there's elastic bands underneath here that are going to help give her active lift of her leg when she walks. So that now that leg that she's really dragging, it's going to give her a little bit of extra lift. So I kind of equate it to power steering in a car. You try and steer it. When the engine's off, it doesn't steer very easily. As soon as you turn it on, it turns easily. It's kind of like power steering for your leg. So the steps in order to put this on. This is called a shoelace strap. And this goes on underneath her laces on this shoe, okay? So when I'm putting this shoelace strap in her shoe, I always want the Velcro facing up. So if it's like this, it's wrong. I want the Velcro facing up. And then when I slide it in underneath her shoelaces, you want the 3 toes down by the toes. And you want the flat edge up by your ankle. So if I put it in like this, I have 3 toes by the toes, flat end up here, Velcro facing up. That's the way I want it underneath her laces. Okay. So typically what I'll do is I'm going to slide it underneath the last 2 X's of her shoes. Okay, so it's going to look like that. Usually I have to untie it or anything like that and then put it on. Okay, so under the last 2 X's, remember that the further out you slide this and you put this in her shoe, the more toe lift you get. But the more toe lift you get from there, there can be a little bit more tendency towards recurvatum. So if they have a lot of recurvatum, then sometimes I'll slide it in a little closer to the ankle and put it in up here under 2 X's. So that's step 1. Okay. So step 2 is then to put on the waist belt. Okay. So I'm going to take this. Nope, I always put this on seated because a lot of my patients have poor balance and I don't want them to fall while they're doing this, so I try and teach everybody to put it on seated. When you put this on, don't be shy. You want it snug. Okay? So if I'm putting it on her, I'm going to get it on there pretty snug, and I'm going to try and get it so that this screw, this medial band screw, is maybe an inch or so to the left of her belly button. Okay? So we're going to set it up there. So that's step 2 to get that on. One little tip is I teach people to build in a little bit of a loop at the end, because like 99.9% of my patients have urgency of bladder, and when they gotta go, and they don't want to deal with fumbling with a belt. So I'm trying to find it so they can grab it, pull it off, do what they need to do, and then they're good. So this was made with Velcro just for that purpose, to get it off quick. So then what you're going to do is get that on there kind of snug. Most people like it kind of riding right on their iliac crests. I've occasionally had people who want it a little bit lower on their hips. It's never going to work with me. It's just going to pull my pants straight down. On her, she could use it. Okay. For most of you guys, you could wear it lower. Okay. Very rarely does someone want it high. I had one lady who almost had it right underneath her breast when she wore it, which is really rare when someone wants it that high. So step 3 is to attach, remember that little Velcro I told you it has to face up? Well, that needs to attach to this Velcro bridge. So you're going to pull it down and then put the Velcro right over the top of that ankle bridge and then clip it. Okay. So step 4 is an optional step. So this is the popliteal strap. So if you look at this strap, it'll go and it'll double over on itself like that. Okay. So I like the medial and lateral bands to kind of fit right where my fingers are. It shouldn't be pulled so tightly that it's overlapping like that. Okay, so you want the medial and lateral bands to fit in there like that, but it's going to fit behind the knee. So typically what I'll do is I'll tell people to put this on one side. So I'm going to attach this right now to a medial band, and you always want the Velcro, the extra Velcro section, facing backwards. So now I'm going to pull this up between her knee and the band and then double it over on itself. So then it sits behind the knee. All right? So then at that point we just get up and we walk. Okay? So get up and go ahead and try that out and see how that feels. Okay? And then just try and walk naturally with it. Because right now it's going to give you like a steppage gait, right? So it's going to excessively hip flex her, and she's going to get a steppage gait because she has normal strength in her leg. But for the person who's got a 1 out of 5 hip flexor or 2 out of 5 hip flexor, it just gives them a little bit of assistance with it. Okay? So the popliteal strap back here, so if you kind of turn sideways, I told you this is optional. I like to use this more with patients who are more spastic, have more extensor tone. So maybe they're like this, and they have very little knee flexion, because what it does is you think of just the mechanics of this and the physics of this. So this is your fulcrum right here. And then you have one force vector going down this way to your foot. You have another force vector coming up this way that's anterior to your hip. And the resultant vector is this way, right? So it's promoting more knee flexion.
It's a tactile cueing too.
It is a tactile cue. So it's a tactile cue. It inhibits but does not stop genu recurvatum, but it will inhibit it. If a patient comes in and they have an AFO, I keep it on. Okay? If they came with a physician prescribed AFO, I am not taking it off. All right? I have them keep it on. That said, I've had some patients who say, oh, I don't need my AFO anymore, and then they stop wearing it. That's between you and the patient as far as how you work that out. I encourage them to stick with their AFO though. So that's the general idea on how to fit this. Now, if she's walking along and she is a 1 out of 5 hip flexor and this isn't lifting her enough, let's say she's still still catching the toe, there's still not enough for her to get a lift, then we need to increase the tension and give her a little bit more tension. And there's 2 ways to increase the tension. So go ahead and have a seat again. So one way to increase tension is simply to take the shoelace strap and zip it down tighter. Right? That's the easy way. And that actually works pretty good in MS. With my MS patients in the morning, don't need that much help, but by the end of the day, they need a little more, so I'll just tell them, just zip that down a little tighter and you'll get a little bit more lift. Okay? If you're seeing them and they're really catching their toes and you want to give them more lift, it's relatively easy to do. In the little package it always comes with this, which is instructions, which is pretty much everything that I'm saying today. And it comes with this little guy, which is a wrench. Okay? So this wrench just fits on here, and then you can loosen this up. Okay? So you can loosen both of these up. Frankly, most of the time you can just do this with your hand, and you don't even need the wrench, but once in a while you need it to loosen it up. So if I wanted to give her more lift in therapy, I just unscrew these. These are what's called compression fittings, and you can take this rubber band and then just pull it out. Okay, and I usually pull it out about a 1/2 inch to 1 inch, and then put it back on, and then I just tighten it down. You don't have to take the wrench and crank it down as tight as you can. Put it on there, finger tight, and it'll be fine, because that compression fitting is squeezing this down, so it won't slide. All right, and then take the other side, pull it out a little ways, okay, and then tighten it down, okay. And then once you've done that, then you can come back here, reattach, and then off you go. And then I'm going to have that same patient go through and do a couple walks for me and see if they're now getting clearance. Because ultimately what your goal is to have symmetrical ground clearance with both feet. So I'm going to look at that good right leg, and I'm going to try and match it up as best I can with the left leg and get some good ground clearance. Okay. One exercise that I like to do, come over in the parallel bars if you would. I call this like the foot in the bucket exercise. I know it's a lot. But I call it, so this is like a gait training exercise that I like to do with people when I'm doing this. So I'll have you come up in the parallel bars. So if you think of just specificity of training, what's our real goal here? We're trying to get a better stride with the left leg. So let's practice strides with the left leg. So I'll have them put the right foot forward, and it's like that foot's in the bucket. Okay, we're keeping it in there, we're not moving it. But then when you're going to take a step on the left, I'll give them a cue to come up on their toe, and then drive through their knee, and then reach with their heel, and then come back. Okay? And that's a really foreign concept to a lot of people who walk like this. So you may even come up here, drive your knee right to my hand, and now reach with your heel, and then step back. Okay? So you can give a little bit of a manual cue here, and a visual cue, and then take a step back. Because a lot of these patients are circumdecting, so that the first thing that comes forward is their toe when they swing their leg. It's the toe is the first thing that comes. But really what you want is the first thing to be the knee, and then come forward and land on the heel. So that's just one thing that kind of helps. So I have people repeat that, like they'll put it on,